Okay. So welcome. Can everyone hear me okay? I have been breaking up a little bit, so I hope it's not a big issue throughout the session. But my name is Maggie. Welcome to the REACH community. I am one of the program coordinators for REACH. And if this is your first time joining, then welcome. If we saw you in January, then welcome back. We're hoping that you all are enjoying. And if you did not get to see if you weren't here for the January REACH session, then we post them. Each session is recorded and posted onto the website. So let's see. Can you all still see my screen? Okay. I'm gonna try to advance it. It looks like there might be an issue. It seems like it's paused for me.
I'm gonna go ahead and share my screen. Oh, it's saying I can't. If you want to unshare yours, I'll share mine and you can just tell me when to advance.
Okay, perfect. Yeah.
It's still not letting me share.
Stop share. Okay.
There we go. All right.
Okay, perfect. And yeah, we'll just go through, this is the first slide. Just some housekeeping things. We are collecting registration data, participation data, chat comments. All of your information is confidential, but for education purposes, we are going to be recording the sessions and making them available, like I said, on the website to everyone. So we thank you for your participation and your consent to be recorded. If there's anything that you have questions on about this, feel free to reach out to our email. So we are excited to offer CEUs to anyone that is interested in receiving them. Let's see. So the sessions are accredited for continuing education units through LMH PCO. Each session is worth 1.5 units. We will take attendance at each session and monitor engagement for those that are here today. There will be a post-session evaluation that's going to be sent to you from LMH PCO following the session, and that does need to be completed in order to claim credit. Additionally, if you are a hospice nurse, you should have received an email from the REACH team to complete an initial survey for our REACH quality improvement project. At 6 months and then the 12-month mark, we'll also be sending or collecting surveys again. And so we appreciate your participation in that. That is voluntary, but for CEU credits, make sure that after each session, you are completing those evaluations. So just some Zoom etiquette. If you're not speaking, we just ask that you keep yourself muted for the duration of the session. We do welcome you to come off mute and speak if you have comments or if you have questions. Feel free to do so. Just unmute yourself and then remute yourself once you're finished chatting. Keep your camera on if you have the bandwidth. We, would like to create a sense of community despite being virtual. But we understand if you're not able to have your screen on. Okay, and then this will help me for collecting attendance. If everyone could go ahead and rename themselves on your Zoom screen, there's 3 dots in the top right corner of your screen. And if you click that and then click rename and then put your first name, your last name, and your hospice organization, that's going to help me for collecting attendance for today. And then, like I said, feel free to come off mute if you wanted to speak. You can also use the raise your hand function or just use the chat. And I'll be monitoring that throughout the session. So some ground rules. Again, thank you everyone for being a part of the community. And like I said, we want to create a space that feels welcome and feels like we are a community despite the virtual platform. So it is a safe space. Your thoughts, your questions, your concerns are all valued and valid. We want to take this this space to, have a welcoming environment. We say take space and make space for everyone. And then finally, what's said here stays here, just like the Vegas rules to protect the privacy of all participants. Just please keep everything that's discussed here confidential. And then if you are going to discuss anything from your personal or work experiences, just make sure you use de-identified information. So the agenda for today, we're going to start off with some welcome and introductions from everyone. We want to get to know you guys. And then Stevia is going to review the objectives for the session today. And then Dr. Mo is joining us as our expert presenter. So she's going to be giving a didactic presentation. And then we're going to follow that up by a case discussion. And then before we wrap up, or right after we wrap up, we're going to be doing a mindfulness activity. So feel free to stay for that if you feel it would be helpful. If you'd like to head out, right after we wrap up, then you won't be missing anything too important. But that will be to close the session, the mindfulness activity. Okay, Stevia.
All right, thank you, Maggie. So welcome for any new members. We're so excited to have you here. And for our returning members, it's so great to see y'all again on Zoom. For those who don't know me yet, I'm Stevia Davis. I'm the nurse practitioner at Children's Hospital of New Orleans with the palliative care team. And I have the privilege of co-leading the REACH initiative with Dr. Autry, who's out on maternity leave right now. So I will be one of your facilitators throughout the year, and you'll be seeing a lot of me over the next couple months. So to start, I'd like to do some introductions if we can. I have the participant list pulled up on my Zoom, so I'm just kind of going to go in order. We have one phone number on the Zoom. It's a 225. If you can unmute, if you're able to. Okay, we'll come back. If at any point you're not able to unmute quick enough, we'll give some space at the end so that you can unmute and introduce yourself. Next, we have Courtney Kelly.
Hi.
Hi, Courtney. So if you just want to give us your name, your organization, and then where you're located at.
I am with LHC. I am the hospice clinical operations coordinator, and I'm located in Lake Charles, Louisiana, but I work for the home office in Lafayette.
Wonderful, thank you. It's so great to have you here. Next, we have Bailey Pinzado. Sorry if I'm messing up any of these names.
I think she completed it. Hi. Can y'all hear me?
Yep.
Hold on, let me turn. Sorry, I'm doing 2 meetings at once right now. Let's see. Hi, I'm Bailey. I am a pediatric hospice nurse. I just started about 2 months ago. I work for the Hospice of Baton Rouge, and I practice all over Baton Rouge, St. Francisville, Gonzales, pretty much anywhere that I can, I do.
Wonderful. Well, welcome. We're so happy you're on.
Thank you so much. I'm glad to be here.
And then we have Tamela.
Hey, sorry, I'm trying to eat my lunch, so I had to swallow my food.
No worries.
And I go by Tammy, but I didn't know if
Tammy?
you all had the
Okay.
list with Tamela or Tammy on it, so that's why I changed it to Tamela. I am the manager of supportive care services at Our Lady of the Lake in Baton Rouge. So it's over the palliative care department. I have an outreaching arm to the palliative care department at Children's as well. Trying to, make sure that we're all kind of doing our processes the same and that kind of thing. So
Wonderful. Welcome.
thank you.
Next, we have Cheryl. Oh, I'm gonna unmute you, Cheryl.
Have to unmute myself. I'm Cheryl Chern. I am I'm based out of Children's, and I'm the nurse navigator for the maternal fetal medicine group. So I follow all the high-risk mother-baby dyads during their pregnancy and follow up with them after.
Wonderful. Great to see you again. Judy?
Hello, I'm Judy Zarang. I serve as the nurse navigator in spiritual care for the Pelican Crew at Children's. Thank you.
Thanks, Judy. Anitra?
Hi, my name's Anitra Dunbar. I'm the administrator of Allegiance Hospice and Palliative Care located in Marksville, Louisiana.
Wonderful. Welcome. Marquetta?
Hi, I'm Marquetta Trice. I'm the Education Director for LMHPCO. Great to be
Wonderful.
here.
Lisa?
My name is Lisa Goins, and I am with North Oaks Hospice, and I am the hospice director, and we are located in Hammond.
Wonderful. Welcome. Katie?
Hi, I'm Katie Elo. I am a pediatric nurse practitioner at Our Lady of the Lake Children's Hospital. I kind of split my time between the inpatient palliative care team and the St. Jude Affiliate Clinic. And I'm happy to be here.
Welcome. We're so happy you are here. Brianna?
I'm Brianna. I'm one of the new social workers on the Pelican Crew at Children's Hospital.
Wonderful. Yay, Brianna. Jamie is next.
Hello, everyone. Jamie Boudreau. I'm with the Louisiana Mississippi Hospice and Palliative Care Organization.
Wonderful. Thank you, Jamie. And Joellen?
Hi, this is Joellen. I am a registered nurse. I'm the executive director of Part of Hospice in the Bayou region, which is Franklin, Martin City, Thibodeau areas.
Wonderful. Thank you for being here.
Thank you.
We have Stacy.
Hi, Stacy Melling. I do integrative therapies at Children's Hospital, work very closely with the with the palliative care team, the Pelican Crew at Children's. And happy to be here. We'll be doing the mindfulness activity at the end. So hope to be able to join something, share something good with y'all.
Thank you, Stacy. And last but not least, is it Jancy?
Hello, yes, my name is Jancy. I'm a pediatric nurse practitioner, and I'm here in Lafayette, Louisiana, doing an inpatient pediatric palliative care program.
Wonderful, welcome. Well, we're so excited that y'all are here and joining us. And we're gonna have some great content for you today. So today for our objectives, we want to recognize that communication is a skill that can be taught. We're going to review frameworks for difficult communication in pediatrics, and then we're also going to discuss ways to address common challenges in communication scenarios. So we are so grateful today to have the amazing Dr. Lexi Morvant join us, where she is our medical director for the Pelican Crew, the pediatric palliative care team here at Chinola. So Dr. Mo, take it away.
Hey y'all, so I'm so excited to be here. And so we're gonna jump right in, and I just want this to be informal. I want you to interrupt, I want dialogue. And we're gonna start off with a question, and there's no wrong answer to this. What are some key ingredients to excellent communication? Unmute and just throw it out there, or we could do a waterfall into the chat and you could just put some things that come to mind in the chat.
I think listening.
Listening, yes. So it's not only what we say, it's creating space to hear back what families are understanding. Eye contact, which goes into our nonverbal communication skills. Thank you, Marquetta and Cheryl. Y'all are brave to go first. What else?
The tone of voice you speak in.
Tone of voice. So our octaves, are we speaking like this, or are we speaking like this? You know, so again, that sort of the things that aren't always the words, it's how we're saying it. Excellent. All right, so when I think of communication, I totally agree with y'all. I think that it's not only what we give families or what we say to our families, it's also the space that we create for them to give it back, so that we can ensure that we are developing shared knowledge over the course of a serious illness disease trajectory. And hopefully this allows us to establish mutual respect and trust over time, so that both parties, so that both the patient family that's experiencing a serious illness and the medical team that is providing the care can express hopes and worries in a safe way throughout a disease trajectory, depending on what we're seeing and what changes they're experiencing. And hopefully all of this sort of comes together to build upon one another, so that we can have what we call shared decision making, meaning that we could understand that a family has good prognostic awareness, they know what to expect in their disease trajectory. We understand their goals because we've created space for them to tell us, so what's most important based on the information that you have. And then hopefully all of this comes together for us to give goal concordant recommendations. And that's how we sort of think of shared decision making. And some other sort of things that come to mind to me for excellent communication is presence. So being able to have mindfulness to where we are still in the moment, our minds are still, so that our families can know that they're the only ones that matter in that moment when they're sharing their most vulnerable sort of thoughts and worries and hopes with us. Compassion always should be at the core of every procedure we participate in. And then this is a term that I use a lot, humble curiosity. I think I made that shit up, but I think that humble curiosity is something that is so important, because I want to always have the humility to say, I can't possibly understand this family's entire story, and also hook that on to curiosity to create the skills I need to continue to be curious, to always learn more from the families that we're taking care of. And of course, we talked about nonverbal communication, which, depending on the study that you see, is about 70 to 85% of all of communication interactions. So it's definitely not just the words, right? It's all of the other things that we do to create a safe space. So the myth that we always sort of hear is that you are a good communicator, therefore you could communicate bad news well, because you're just naturally good at it. And actually, delivering difficult news and having difficult conversations with families, especially pediatric families who are experiencing sometimes the worst moments of their lives, really is contingent upon developing a skill set. And each individual medical clinician, whether you're a nurse, a social worker, a chaplain, whatever your discipline is, you have to be intentional of sort of polishing up your communication skills that are coming from your toolbox. It's not something that just comes naturally. And the reality is that this is teachable. So hopefully you leave today with some skills that then you could practice and be intentional about using within your day-to-day experiences with your patients. And so one of the things that's really important in communication is the language, right? And that is one of the most important tools in hospice and palliative medicine, is the language that we use in order to ensure we're making authentic connections with our patients, and that they're able to feel safe enough to tell us their beautiful stories of love and perseverance in their hopes and worries. And I'm a firm believer that the way we speak to our patients and about our patients, even when they're not around, actually affects the care that we're providing. But more importantly, I think it affects the joy that we will experience as clinicians as we continue to do this work. And I try to have the intentional practice of speaking about my patients when they're not here in the same way as if that mom is standing right in front of me. So if I'm talking to colleagues outside of a room, if I'm writing my notes alone in my office at 10 p.m. at night, I am trying to channel my language to be intentional as if I am speaking right in front of that patient. And it allows me to remember my privilege in this work. And it's not just another day at work for this family that I'm taking care of. And what I hear from families all the time, it's not that they don't want to know the tough information. It's not that they don't want to know the prognosis. And they oftentimes say it's not what they said when they're upset. It's not what they said. It's not that I didn't want to know. It's how they said it. And I feel like language empowers us to humanize our patients and to allow us to remember it's not just another day at work for them. And it allows us to see our patients and their families as humans and people with complex stories and values, as opposed to just a disease or a checkbox on our very long to-do list for that particular day. It reminds us of the honor and privilege of delivering care in serious illness. And this is one of my favorite quotes. And if you don't know Dr. Eric Cassell, he was one of the first physicians to write about the experience of human suffering. And this is from his book from 1978. He just died actually last year. But he says, similar to scalpels for surgeons, words are the clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. And so too should clinicians who rely on their words. And the reason I share this is because we have to remember that the words we use are going to impact a family's grief story far beyond the time that their child is no longer physically on this earth. They're going to remember these conversations. They're going to remember the words you chose to use. And so each interaction we have within that serious illness context is going to be a lifelong memory for families. So this is the first skill that I want you to take away from today, spikes. And just with a raise of hands or in the chat, who has heard of utilizing spikes to deliver difficult news? I see some hands. Yeah, all right, very cool. And don't worry, if you haven't heard of it, that's why you're here, right? So spikes, there's a ton of different modalities in the literature of how to deliver difficult news. Many different, and nothing is evidence-based to say this works better than that. We like spikes because it's straightforward. So S is setting and actually getting a good start to what we're about to do. P is perception. I is invitation, K is knowledge, E is emotions, and S is summary. And we're going to go through each one of these things together. And I want you to, I know I speak quickly and I know I go fast, so I want y'all to slow me down and ask questions if y'all have any, or if you disagree with what I'm saying. I love that. Be brave. So setting. So anytime we're about to engage in a serious illness sort of communication, especially if it's delivering difficult news or some kind of new information, presence, right? To create safe presence, the first thing is to find a quiet space. So we shouldn't be having these conversations in the hallway, right? We need to have the littlest amount of distractions possible. We also want to make sure that we're setting the families up for success to feel safe. So you might want to say, hey, I have we have some challenging things to talk about. I'm wondering who would be important to be there to support you. So make sure, maybe their pastor, maybe it's a single mom and she wants her pastor there, or her pediatrician, or her hospice nurse, right? We want to make sure that we have a multidisciplinary team, meaning that we have someone to attend to the psychosocial aspects of suffering, the spiritual aspects of suffering, maybe the physical aspects of suffering, so that we could all come together to support that family through this process. You want to make sure you have tissues, but I have a caveat about tissues. Listen, anytime a human being starts crying, it's really way easy for all of us to be distracted, to be like, where's the tissues? Because it's much easier to go look for tissues and like make sure we have tissues than to bear witness to suffering of someone being sad and crying. And also, we want to make sure that when we are utilizing tissues, that at the beginning of the meeting, you place it in a place where the family could reach out for the tissue if they want it, but we are not pushing the tissue at the family, right? Because like if 80% of all communication is nonverbal and I'm pushing tissues at you and you're crying, what could that potentially mean to the family?
They could interpret it as though you don't want to bear witness and support them during their suffering.
Is that stop?
Or quit crying. Yeah.
Stop crying, right? And so I place it strategically where they could take it if they want to, and then I never touch it again, because some people are going to want to cry without tissues, and they just want snot, and they just don't want to be bothered with a tissue, and that's okay. Grief looks different for everyone, right? We want to make sure our cell phones are off. Everyone has chairs. We want to make sure we sit down. There's actually a study that showed if you sit down as the medical clinician, whether you're social worker or whatever, if you sit down in that encounter, families perceive 30 additional minutes to that encounter, 30 more additional minutes. And make sure at the very beginning that everyone introduces themselves, because one of my biggest pet peeves is when we all say, oh, mom, you know me. That's not, they meet so many people, they may not know you, right? And then also if they invited someone like maybe the matriarch of their family, who's actually the person who's helping them with decisions, I want to know who that stakeholder is. So just get in the habit of creating space and doing introductions in the very beginning. Perception. So this is very important. So you want to know before you start with the delivery of difficult news, what does the family already know? Because that's going to really gauge how I'm going to interact with this family and what kinds of, what approach I'm going to take. So one of the things you might start off with is, tell me what you've heard so far about what's going on with, and you use their name. Don't ever say your child. Use their name, right? And don't say mom. Say, Lexi, can you tell me what's going on with Bella? That's my dog's name. Or what have the doctors said about Bella's illness? If it's someone who's older, like an adolescent, tell me what you've been feeling in your body. You want to look for that they have a good understanding before you start, or at least, I'm preparing my heart that if they have no idea what's going on and I'm about to kind of drop a bigger bomb on them than what I initially thought. So it's just a way of preparing our hearts of the approach we're going to take. And then when they're talking, don't interrupt. And then we want the I in Spikes as invitation. So we want to know that the family is ready to hear and that I have an invitation to share what I know and potentially fill in some of those gaps. And so we're exploring for that information and perception. And then I'm saying some families like to hear all the details. Others prefer more of just the big picture. How do you like to hear medical information? Or I might say something like, I have something really challenging to talk about today. Is that okay? Is it okay if I share what I know? And that way we're giving the power to the family on the informational exchange cadence, so that at any point they could say, nope, I would rather not hear that today. And then you could follow up with saying, can you tell me what else I could be doing to support you? Because I do think it's important that we talk about this thing, right? So you could explore the barriers and they might say, I have to go get my kids in 5 minutes. I didn't know we were here for a big talk, Dr. Mo. So something logistical like that. Or you want to be, specific. Would it be okay if we discussed the scans that we just learned about today? So you want to make sure you have space to move forward. And then in Spikes, K is knowledge. So that's sort of like saying the thing, right? And the implications for why the thing matters. So many times, this is mostly nurses on this call, and I'm a doctor, so I can say this. Doctors love to hear themselves talk like I do right now, and they're going to say all of the different things, right? And we're going to not be able to delineate the difference between the trees and the forest. We're going to start talking about creatinine and the lung function test and the cholestasis and the bilirubins and the blah, blah, blah. We're not very good at presenting the big picture and the implications of why that matters. And the other thing is, before we start to deliver difficult news or say the thing, I like a warning shot. Some people feel that warning shots may or may not be helpful. I personally always use a warning shot, because then that allows families to know we're about to talk about something tough, and you could still tell me I'm not in the headspace for that. So I might say, gosh, I really wanted to talk about the scans today, and I'm so sorry to say the results were not what we were hoping for. Is it okay if I share what I know? And again, I'm giving them permission to say no. I'm giving them permission to close the box and say, let's reset and talk about this another day. Or you could just say something like, I have something very serious to discuss. This might be really hard. Is it okay if I ask a tough question or if I share some tough information? And then you do what we call the headliner. You say the thing and the implication. It should be 1 to 3 sentences, right? I am so sorry to say your scans came back and your cancer has gotten worse despite our best medical efforts. And there's no more treatment that's going to be available to cure you or make you better, right? That's 3 sentences. And that is big picture and the implications of why that matters. And then Ask, Tell, Ask is always a really great tool. Has anybody heard of Ask, Tell, Ask? Yeah. So again, I use Ask, Tell, Ask as that setting the cadence and the informational exchange. But another way to use Ask, Tell, Ask is to say, can you tell me what you've heard, right? That's that perception. And then they say the thing, can I share more about what I know? It might be really hard to hear. They say yes, and then I share more. So it's kind of Ask, Tell, Ask. We use it in education a lot too for like teach back. So I might teach you something and then I say, hey, can you tell me what we just learned? And then you give me a pearl. So it's just kind of like creating dialogue. So if we say the thing, right, and the implication of why the thing matters. So another example would be, I am so sorry to tell you that the scans have shown that the chemotherapy and radiation did not work. We do not have any other treatment to help make your child better. And despite our best efforts, Bella's time on this earth is short. She's dying, right? Using the D word can be extremely powerful and meaningful to families because everyone understands what the D word means, but we so often don't use it. We might say this was unsuccessful, this didn't work, right? And then families might follow up with, well, what do you mean by that? What's the next steps? What else are we going to do? So K, think of it as knowledge. It's the headliner. It's saying the thing to the point, no euphemisms, right? Big words, medical jargon, try to stay away, keep it simple, because that's going to be one of the most devastating moments of a family's life. And if we said the thing and they've meaningfully heard what we're trying to say, we have to prepare our hearts for emotion. We get quiet, right? We bear witness. And then you observe the room of what the emotion is. I could tell this is so shocking for you. I am so sorry. I wish the news were different. I cannot possibly imagine how hard this is for you right now. Your emotion right now is expected. It's okay. Just cry. I'm here with you. And then silence is sort of golden, because I think so many times as human beings, and take this out of the context of serious illness, when your spouse or your child or someone's sad, or going through something tough, you just want to fix it because that's what human beings want to do. And sometimes we have to recognize and have the humility that our words are not going to be enough to fix something that is so devastating. And silence and empathic presence can be so powerful for a family. And in fact, sometimes too many words can be harmful. And it can make things worse. And sometimes we say the hard things and then we see that it causes emotion and then we try to take it back. Well, it's not as bad, well, maybe we could think of this and, and that's where our self-control needs to come in play of when our words can and cannot be helpful. And
Can I ask a question about
sure.
that?
Yeah, Katie.
So yes, silence is golden, and I love that. What do you recommend, like when you're in a room and someone else in the room, whether it's a resident, a social worker, child special, someone says something that we don't want to say? So say they said, I know what you're going through, my grandma died last week, like I've had that happen, and I don't know how to recover from that in the room in the right way.
Group, what do y'all think? So when someone starts to try to have an empathic comment that actually makes a family, and when we say, I understand what you're going through, and the family gets really upset, how do we recover from that? They say, how could you know what I'm going through?
Right. Or they just get silent and then you kind of lose the rapport you were building.
So that's where my role as the team, as the team leader or the nurse, the hospice nurse, I think that's where our role is to redirect. And we quickly intervene when we see that emotional sort of response, when someone has said something that is, they're trying to do well, but then they do the too many words thing, and then they cause a little bit more harm. And I think that's where we step in and we kind of take over. And sometimes I've even put my hand on a learner to just kind of tap them, and then I start talking directly to the family. Or I then say something like, would it be helpful if we gave you some privacy right now? If I said the thing, they understand the thing, right? And then I'm realizing that I have some variables around me that can't control what's going to happen next. At that point, it might be time to dismiss people from the room to give the family more privacy too. Any other ideas? So, thank you, Katie. That was a really great question, because that's what happens in learning environments all the time. So the other tool that you have is NURSE, and that's name, understand, respect, support, explore. So this is when you're bearing witness to emotion. Name is like actually naming the emotion that you're seeing. I can see how overwhelmed you are. Understand is saying, gosh, what you're feeling is so expected. Or if you're kind of like unsure, understand could also be like a curiosity. Like if it's really silent and they look very stoic and you have no idea what's going through their mind and you feel like you're reading the room, that their space, I sometimes ask, can you tell me what's going through your mind right now? That's another way of trying to understand. Respect, anyone that would be going through what you're going through would feel X, Y, or Z. Support, I'm here for you. I don't have any words that could fix anything right now, but I'm here for you. You're not alone in this. And then the explore is sort of that curiosity piece too. Tell me more. And just remember, nonverbal communication is 60 to 80% of our communication, body language, eye contact. Be careful with touch, especially post-COVID or within the COVID era. And I think masks have really challenged our nonverbal communication. I don't know about y'all, but man, I miss just seeing the faces of our patients because there's so much missing in my calculation of what's going on. So going back to spikes is S, summarize. So this is where you want to take, you feel like, okay, there's been enough silence. There's been, you know, the emotions are coming down, or maybe the emotions are just getting higher and higher, and you're realizing the family wants to be alone together. You offer privacy, but what you want to try to do is summarize without downplaying what you just shared, right? And then talking about what the plan is for the next steps. So you might say something like, we've talked about a lot of information. I cannot imagine what you're feeling right now and how overwhelming this is. Is it okay if I summarize what we just talked about? And summaries can be very powerful. And again, just go back to your headliner. Don't go into more detail. Don't downplay what you just said. And then you could say the next steps are, let's focus on pain management tonight. Let's get them comfortable. And then tomorrow we're going to come back and talk about what the next steps are going to be. And that way families know, okay, we have a plan in place, you know. And the other thing I'm going to mention is that at the beginning for the P, the perception, if you say, can you tell me what you've heard? And the family just says the bad news that you were about to deliver, that might be the family who's going to be prepared to talk about the next steps today, right? So you might have to do your homework to be prepared to talk about, you know, goals of care, advanced care planning, like the plan. But for the most part, sometimes we put way too much on our agenda of what we want to accomplish with a family, especially if they're the family who said, you say, hey, like, what have you heard from the doctors? And they're like, oh, well, we think he has strep throat, but it's like a brand new cancer diagnosis. They're not going to be ready to talk about the chemo and radiation and all of that, right? But if they say, I know this, I have the feeling the scans are bad and he's worse and there's no more treatment options, they may be the family that wants and is prepared to talk about more. And then you want to make sure they know if you have any worries or questions or you talk to someone, this is the number that you call. And this is the perfect thing for the hospices. So when you get stuck, I always like to say, like, if I'm seeing that I just messed up and said something that, you know, maybe I'm the learner, Katie, that says something that just makes a family upset, I just say, oh my, I am so sorry. I didn't get that right. Can you tell me that again? Right? Silence, tell me more. You always want to make your assumptions explicit. That's another term I use all the time. We want to make assumptions explicit. So if a family says something that might be a little ambiguous, I always want to say, tell me more about what you mean about this, right? And a good example is that I had an adolescent one time. We were in a family meeting. We had just shared, we heard that they had heard about their diagnosis or the worsening disease. And then at some point she says, I just don't want to be here anymore. And, you know, when a hospice palliative care doctor hears that in someone who has a serious illness, my brain goes to like, I just don't want to be here, like on earth anymore. Like I'm tired of treatment, you know? And so, you know, there was two ways you could have pivoted that. You could have said, gosh, it sounds like you really just don't want to do treatment anymore, right? Or you could say, can you tell me more about what you mean by that? And so I said, tell me more. I went with the tell me more. Thank God. She goes, I am so sick of your voice and I just need a break. And so I'm like, so glad I, you know, read the room. And then I wish and I worry or I wonder statements. This is when families say, well, you know, if you just said that cure is no longer possible and they say, well, they're definitely going to be cured. I believe in a miracle. You could say, I pray for a miracle too. I hope for that cure. I also worry, given what we understand right now, that that's no longer possible, right? So you're still building rapport. You're not saying that's not possible. You're still kind of aligning, and then you're still inserting the worry. And I wish and I worry statements can be very, very helpful at building rapport as well. So it allows us to sort of align while also being truthful and not, you know, propagating false hope. You always want to address guilt. Families, parents especially, will always feel that. There's nothing that you could have done differently. There's nothing that you could have done to predict this. You are just such a wonderful parent. You're doing all the things that you could possibly do to make your child better. And I think that some other things to consider just when we talk about language is calling a person by their disease. We always want to be person first. If we call someone a sickler, a cancer patient, a DNR patient, it diminishes their story and their humanity. Never tell a family to cheer up or don't cry. Be careful with the God doesn't give you what you can't handle, because you don't know what they're thinking about what God is giving them, right? Or that everything happens for a reason. It's something that we say in society, but it could cause a lot of disruption about their spiritual coping and how they're understanding their situation. Also, we don't want to silver lining it. That's another thing that humans try to do to make sad situations better, but don't silver lining it. Don't, if you feel those words, at least, and this is what your spouses and your friends, like anybody, if they just shared something sad or bad, and your reaction is, well, at least just bite your tongue. Whatever comes after that is diminishing their experience. Never ever say, I know how you feel. We can never possibly, we have to have the humility to know that we can't possibly understand how another human being is experiencing the thing that they're going through, versus I can't imagine, or I can only imagine what you're going through. We should never ever say there's nothing more we can do. There might not be any more intensive interventions we could offer to achieve the goals we set out to achieve in the beginning, such as cure. And also we have all of these other things that we could re-goal to prevent suffering and to intensively focus on comfort. We never, ever, ever withdraw care. Ever. We always care. There's always care that we could provide. It could be interpreted as abandonment. We don't call patients by their resuscitation status. We never, ever call someone by their ability to live. That terminal patient. That patient may be living with a serious illness, right? But they're not a terminal person. And narcotics is a legal term. Opioids are a pharmacological agent that we give for pain. Narcotics is a legal term. We don't use the word narcotics. And we need to get rid of battle analogies. We need to stop making serious illness into some kind of winner-loser sort of experience for patients. They've won this battle, they were beaten, they could do every single thing right, and medicine is just not good enough. And we have to remember, this comes from Brene Brown, that compassion is fueled by understanding and accepting that we're all made of strength and struggle. No one is immune to pain or suffering. Compassion is not a practice of better than, or I can fix you. It's a practice based in the beauty and pain of shared humanity. And we need to dispel the myth that empathy is somehow walking in someone else's shoes. Rather than walking in your shoes, I need to learn how to listen to your story that you tell about what it's like in your shoes, and believe you even when it doesn't match my own experiences. All right, that's all I got. Case discussion or questions? Do y'all believe me? I mean, did I say anything that you're like, Dr. Mo doesn't know what she's talking about? Or I've had different experiences? No? All right, Stevie, you're up.
Okay. Lexi, are you able? Thank you. So just a reminder for our case discussion, you can always submit any case discussions to the LMHPCO website. We welcome all different variety of topics. So get them in. We will go through them with y'all. So for our case today, we have a 16-year-old patient, Megan, who has a hospice diagnosis of metastatic rhabdomyosarcoma. She's been enrolled in hospice for the past 4 months, during which time she has concurrently been receiving oral chemotherapy with the goal of life prolongation. Over your last few visits, you've noticed that Megan is having a harder time getting around her home. She appears weaker to you. You've also noted that she has to take breaks while walking due to shortness of breath and has declined oxygen when you've offered. During your visit today, she is tearful. When you ask her what's wrong, she cries, "I think I'm dying. Am I dying?" So our questions for the experts are, what are some ways you might respond to Megan?
Am I an expert or are you?
You are the expert.
Is
You're
this
the expert. And if you go to the next slide, you can ask any additional clarifying questions that you have, or if the group has any more questions, this is where we make it a group discussion.
so do I talk? Sorry, I didn't. Yeah.
Yes. So
Sorry.
what we want to know from you are some ways that you might respond to Megan.
Wow. Okay. So first of all, I just want to name that for me personally, as a physician, one of the things that I am most challenged with are our adolescent patients. In some ways, I see them as these incredible young adults that have already began to dream and have already made life plans for themselves. And for me personally, from like a countertransference perspective, these are always the toughest cases. And also, I think the other thing we have to acknowledge is that kids, whether they're adolescents or 6 years old, will always know more than what we give them credit for. They are listening. They are picking up pieces and parts, even when they're on their iPads or iPhones looking like they're not paying attention. And so the first thing that always sort of crosses my mind when anyone asks me, hey, Dr. Mo, am I dying? Is my child dying? I'm always curious to wonder why. Why are they asking that now? And so what I usually would do if someone's asking me that question is tell me, can you tell me more about why you're asking? That's a really brave question. I could tell you're really scared. And it creates more space for them. Again, that's the perception piece, right? That's ask, tell, ask. Because I don't want to just say, yes, that's what I've been told, right? I want to make sure that this 16-year-old brave young woman is prepared to hear what I may have to say, and or that they probably already know the answer to that. And sometimes when families are able to answer their own questions, and then you could confirm, that's my worry too. It's a completely different experience. And she says, I think I'm dying. Am I dying? I would ask, can you tell me more about why you're feeling that way? What are you noticing in your body that's making you feel that way? What do y'all think?
I think what's important too is, paying attention to your body language and that nonverbal communication. It's easy, especially if the parents in the room, having this conversation, to kind of bolt your eyes and look at mom or dad to kind of see what they're thinking, how they're responding. But especially these teenagers, they notice everything you're doing. And so just a quick eye glance that they notice, I've had a patient tell us, it feels like you're hiding something from me. Every time you look at my mom, or that my mom goes out, even if mom is going to the bathroom, like she thought we were having these conversations without her. So I think just paying attention to just everything in the room is important in cases like these.
Thank you, Katie. It's so true. And also, if we are able to have had, like this says 4 months that she's been enrolled in, for concurrent care. So hopefully, right, with early integration of palliative care, early integration of hospice, we've been able to already know, how does this adolescent like to receive information? What are her preferences? What are the dynamics between her medical team, and her family, right? And so that might be our opportunity to take back and take stock of like, what have we already learned over these last 4 months of getting to know this family? Because maybe we asked some of these difficult questions in the beginning, and we could go back and say, okay, so Megan really wants to hear as much information as what her family knows, right? Or she hasn't wanted to know anything this whole time. And she's just deferred to her parents to hear all of this information. And so maybe there's a change in how she's wanting to receive information too. But hopefully we have a few things that we've learned along the way, right, Katie? That's what I'm kind of getting at, like that longitudinal relationship to where you're not walking in for the first time to this question. Potentially.
And Dr. Mo, I wonder if this was maybe one of the first times, or you were early on in your relationship and you experienced this question, if you would respond any differently or use any different techniques to respond to Megan's question.
I think I would probably, well, it depends. So anytime you ask a palliative care doctor any question, the answer is most likely it depends, and that's like the right answer, right? But it depends. But for the most part, I would always face that question with curiosity. And I would still go through spikes because I still want to assess perception. I want to make sure I have an invitation, and I want to make sure I know why they are asking that question too. And that's because I think as doctors, like sometimes we knee-jerk react and just like answer the question scientifically. Yes, I think you have 57% chance of, dying within the next 6 months, or something very robotic that we've learned from some kind of lecture, right? But this is a human being experience. This is humanity. There's no book or calculation that we could have. And this is about making an authentic connection of trust so that Megan knows that when she asks Dr. Mo something, I'm going to be curious. I'm going to be gentle. I'm going to make sure I don't share information she's not ready to hear. And she might say, sometimes I've had adolescents specifically say, when I've asked, hey, I think I'm dying. Am I dying? And I'd say, well, tell me what's going through your mind. What is making you feel that way? Tell me more so I could best answer that question. And they say, well, I know that I'm graduating in May, and that's 6 months away. I don't think I'm going to be able to graduate, and then it's like about a reason, right? Or they're like, tomorrow is this thing and I'm worried I'm going to die tonight. And we know that they most likely, barring some, unforeseen event, they probably have months to maybe a year, so it could be the other way around. But I think always stopping what you're doing, being present, having compassion, being curious, and ensuring that you're assessing their perception and who they need to be there to hear this information, potentially for the first time, is really important before you just say the thing. Never lie. That's the other piece of this. No one, and I mean no one, wants to tell a 16-year-old person that they're dying. And the easiest thing to do is to say, I don't know, I'm gonna, no, you're fine, right? I'm gonna talk to your team and like back out of it. But I think the more brave thing, even if you don't have that information, and if you don't, right, you could say, tell me more about why you're asking that. What's worrying you the most? What are you hoping for? What do you think's going on with your body? Ask some questions and then say, I don't know the answer. Can I get back to you? Could we talk about this? Because you might not know. You might have walked in for the first time and you're going in to deliver some meds, and then she's like, you know what I mean? Does that make sense? And so it depends.
Wonderful. Thank you so much. I think that was really helpful for all of us to talk through. Anyone else in the group have any questions or thoughts on the case?
I think I got everything. Haha. Yep. I didn't even read that slide, but I think I got it.
I would have no doubt about that. Okay. So if we don't have any more questions, we can start wrapping up. The next slide is going to show us our resources that we have for further communication tools: Courageous Parents Network, the Conversation Project. St. Jude has more, and then if you check out the LMH PCO website, we have a little pocket guide that has the spikes and the Ask Tell Ask. I think it's about a like 2-page document that's really helpful. It's kind of shortens things up for you. And then I believe, Dr. Mo, you have another one that you
Yeah,
wanted to mention?
I think one of the most powerful resources that you can look at is something called Vital Talk. It's a free website, and also you could download it on your phone for free. And it's probably the most sort of evidence-based, highest yield communication platform that we have in serious illness care. And it has online, it has a ton of videos. It has a ton of scripts so that you could do role play. And it also on your phone, it has all of these things, and you could get a Vital Talk tip of the day, or you could turn it off. It doesn't matter. But you could go in and it has all of these different scenarios of exactly this, doc, am I dying? And all of the ways you could think about attending to that. It's called Vital Talk. And I'm actually a Vital Talk faculty, and there's tons of training that we're hopefully going to be able to do to put on a Vital Talk conference here, hopefully in the next couple of years, to where you could come get trained to be a Vital Talk expert too. But all their resources are free, and I think it's probably the best communication tool you could have, or resource.
Great, thank you. And I do think those Vital Talk videos are super helpful. So great resource to check out.
Are there any other questions that anybody has? I think we go till 1:30, but is there anything else that while I'm here that y'all want to pick my brain about? I had so much Diet Coke. I'm like so ready to answer any questions or chat.
I do have a question.
Yeah.
I'm Bailey, work hospice of Baton Rouge. So with like the case study with a patient who's like 16, okay, and you're discussing death with them. I have a patient who's more around the age of like 10 or 11. And I guess my question is like, do I approach it in the same way at that age? Or is that something that has to be like worded in a different way or discussed in a different way?
Great question. What does the group think? Anybody have a perspective?
That curiosity thing that you always go in with, from what I've seen, I'm not usually the one who does it, but I've seen Dr. Mo do it lots of times, going in and being curious and wondering why. Seems like is effective.
Yeah. So always being curious, I think, is helpful. And also we have to acknowledge the complexity that is pediatrics, right? So one of the things that's very different than the adult world is that there's different developmental milestones that kids are going to go through as they sort of progress into that like midnight hour where they turn 18 and suddenly they're an adult, which like legally means something, but in the real grand scheme of things, it doesn't. And so we have to be aware of developmental milestones. So and Stevia could probably send this out, but there's this great chart, and it actually is an evidence-based approach to talking about death and dying based on, assumed and like researched developmental milestones of different ages and how they're going to understand death even as early as 2 years old. Versus, and then how to explain it. So, and it also gives tips about like, we shouldn't say, oh, they went to sleep. Right. Like,
Right.
because then they might hear that like anytime they go to sleep, like they might die. Right. And you have to take into consideration the concreteness based on their developmental milestones as well. And so we could share that with you. And so I would
absolutely love that.
Yeah, just like Stacy said, I would assess with curiosity. I would have the family there. That's not going to be a one-on-one conversation I would have with a 9 or 10-year-old.
No.
Right. We need to be able to
Right.
on our interdisciplinary team as well, utilize our child life resources, make sure we have psychosocial expertise with, our social workers, psychologists. And we need to make sure we have permission from the family of how much we're going to explore. And I will say the flip side, the most difficult cases that I have encountered is when the family is saying, I don't want to tell my kid. Even as early.
And that's the situation that I'm in right now.
Yeah, so even as early as 6 years old. So there's our 7, there's something called the rule of 7. So I'm a medical ethicist by training too. So this is an interest of mine. So what we say in ethics is this paradigm of the rule of 7. So by 7 years old, kids should be able to assent into treatment plans. So we need to tell them what's going on, and then they go forward with what the care plan is. And by the time they're 14, we think that their developing autonomy is beginning. And that's actually the first court case in Louisiana, in the United States, that actually allowed a 14-year-old to go against the wishes of their parent and discontinue life-sustaining therapies despite what the parents wanted. And so there's not anything magical that happens at midnight other than a legal sort of precedence when they turn 18, right? So you have these like developing adults over time. And so the way that I deal with, I don't want to tell my kid, is with lots of compassion and curiosity. Curiosity is so important because many times, and I would say this is anecdotal, but 95% of the time, it's because a parent has no idea how to talk to their kid about dying.
Right.
Right. The second thing is that they are so terrified that they're going to make things worse, or that they're somehow going to say something that's going to make their kids sicker. And then in the deep South, and I'm making this shit up, but I call it the juju effect, that like there's families that I meet that say, I don't want to talk about the thing because that means the thing is going to happen.
Right.
I only call it the juju effect. There's probably some much more polished way to say it, but like also exploring that. So exploration is so important. And then education. We have studies that show that kids know a lot more than what we give them credit for. And actually, by not creating space for them to talk about what they likely already know, can cause more harm, depression, and anxiety. Here are all the tools we have to support you, and then giving the family the options of saying, we can send a child life specialist and a doctor and a social worker in with you to share this information with you being by our side. We could give you the tools to share it and be by your side, or we could do it with them and you don't have to be there. But it should come from someone they trust. Now, the other caveat to this is that we have to respect the family dynamics that's already been sort of foundational to how this family functions in general, right? So there's going to be, especially adolescents, there's going to be kids that say, I don't want to know any medical information and I depend on my family to make all the decisions. So that's the other thing you have to explore. What has been the communication sort of preferences of this particular family, right? How have y'all, what does the kid want to know? And the worst case scenario is when, despite your best efforts, you know, you explore, you tell them about the literature, you tell them about the studies that we know, you give them the tools, they still are saying, no, 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 I don't want to tell them. And also the kid is asking the questions. But sometimes you just have to be respectful that the kid's not asking questions. They trust that their parents are making the right decisions and they really just don't want to know. And at some point they're going to be ready to ask. But I don't think, I guess the point is that I don't think we always have to share every single medical piece of information we have without, again, that ask, tell, ask, and having an invitation, especially from a kid. And then if they still decide, despite, you know, and let's say the kid is like 16, they're asking every day, what's going on with my body? The family is saying we can't tell them. Then you have to get ethics and legal involved eventually. And I've only seen that happen one time. And it was because the kid had desire to know. The family was counseled multiple times. And then once they were able to talk about it, the family actually did really well together. And they were actually able to do a lot of legacy building, but it was not good. It didn't feel good to get to that point. This is what I'm saying.
Yeah, of course.
Does that answer your question?
Yeah, thank you so much. It definitely does. Thank you so much.
Awesome.
Anything else from anyone? All right, well, Thank you all so much for joining us for our second REACH session. I know Dr. Mo provided us with a lot of great information and clinical pearls that we can all, even if we already know the tools, great to be refreshed and have her perspective on things. So after this session, we will have the recording uploaded, and remember on our LMHPCO website, we have our curriculum overview, the registration form, case discussion form, and additional resources. So I will also make sure that we upload the developmentally appropriate stages of how our patients think about death. Make sure you complete your surveys to get your CEU credit. Always, you can reach out to us via email with any questions that you have or suggestions. And then our next session will be on March 16th. Dr. Mo will be our facilitator and I will be the presenter, and we are going to be doing a management of neurological symptoms.
Stacy, do you want to do your mindfulness exercise?
Yep, I'm ready if y'all are.
All right, so that concludes our session portion, and now we'll move into mindfulness.
Okay. Just another thanks to Dr. Mo. I always learn a little bit about communication every single time we have any kind of something. So I always appreciate that. So this mindfulness, I think usually when we think about mindfulness, I think about like a meditation or something like that. So this is going to be a little bit different, just to explore kind of the power of our mind and how important those things are. So we're going to do a little bit of an imagery. So if you're comfortable, it's going to be most effective probably if you can just close your eyes so that you can get the most out of this. And it's not going to be too long. I'm not going to drag it out, but I just want to give you a little experience. So just take a deep breath and allow your eyes to close. And picture yourself for a moment standing in your kitchen. Either your kitchen or a favorite kitchen of someone you know, maybe your grandma's kitchen or a kitchen in your childhood home. Take a few moments to imagine that kitchen, the color of the countertops, the appliances, the cupboards. Notice if there are windows, maybe curtains. Also notice any kitchen smells or sounds, maybe the running of water or dishwasher, the hum of the refrigerator, or the clicking of a clock on the wall. Take a moment to notice everything, using all of your senses, what you see, what you hear, what you smell, and how you feel being in that kitchen. In front of you is a cutting board. Next to the cutting board is a good sharp knife. Imagine that on that cutting board sits a plump, fresh, juicy lemon. In your mind, hold the lemon in one hand, feeling its weight, its texture, its temperature. Place it back on the board and carefully cut it in half with the knife. Feel the resistance. Pay attention to how it gives way as the lemon splits open. Notice the pale yellow of the pulp, the whiteness of the inner peel. See whether you've cut through a seed or two. Carefully cut one of the halves into two. Notice where a drop or two of juice has purled on the surface of one of the quarters. Now imagine lifting this lemon wedge to your mouth. Smell the sharp, fresh scent. Take it in. Now bite into the sour, juicy pulp. Notice how your body reacts, your face, your mouth, your thoughts. Take a few moments to capture that experience. And when you're ready, take a deep breath and open your eyes. And I'm curious, did anyone at any point, did their mouth kind of salivate? Yeah. At what point? Do you want to share just at what point? Was it when you bit into it, when you smelled it, when you saw it?
When I bit into it.
Mhm. Yeah. That's the power of mindfulness. When we think about mindfulness as just really being just that prayer or that meditation and really breathing, but our minds are very, very powerful. And when you really put yourself in that place. So I'm just going to give y'all a fun little experiment to take with you as you go. I'm going to give you an experiment for the next 24 hours and then for the 24 hours after that. And for the next 24 hours, I want you, when you leave here and you're driving around, count the number of brown sedans. Just count the number. How many do you see driving here, there, wherever? And then the next day, I would like for you to notice, well, I want you to think about before you do this one. How many green cars did you notice on your way to work today? Or in the last 24 hours? Now, I saw Masood and I gave him a hint, so he might have noticed a few today. But how many did you notice? And if it's just think about that, how many? So the first 24 hours, do brown sedans. And then the second 24 hours, I want y'all to notice how many green vehicles or cars that you see when you're driving back and forth, just in a 24-hour period, and just count them. And just to kind of challenge yourself to that, because that's really kind of mindfulness, and pay attention to where you put your mind and where you put your attention really will grow. When you put your mind on that lemon and bit right into it, right? What happened? So that's it. Just a short little mindfulness thing to get our minds kind of juiced up and working. Any questions or comments about that?
No, but I puckered up when you had us bite into the lemon. Like, I know, I was like, ooh. So thank you so much, Stacy.
All right, y'all, we get a few more minutes back in our day, if that's ever possible, right? Such a pleasure. Again, thanks, Dr. Mo. I always learn so much from communication was so great. I appreciate that.
All right, and thank you everyone else for joining, and we will see you next month. Bye, y'all. Happy Mardi Gras.
Bye-bye.
Bye.